Hello folks, I am Dr. Syed Kazmi. This time I am using AI to make you understand a tricky topic of chronic pain in children after an injury. As a doctor and a parent, I know there is nothing more distressing than seeing a child in pain. We expect a scraped knee from a tumble off a bike or a sore arm after a fall from the climbing frame. This is what we call acute pain. It's our body's brilliant built-in alarm system. It shouts, "Oi, something's wrong here. Stop what you're doing and pay attention." This type of pain is a useful messenger. It tells us an injury has happened, and it guides us to rest and protect the affected area so it can heal. Normally, as the tissues mend over days or weeks, the pain signal fades away, the alarm switches off, and your child gets back to the important business of being a kid. But what happens when the alarm doesn't switch off? What if the injury has healed, the cast is off, the bruise has faded, yet the pain remains, a constant, unwelcome guest? This is what we call persistent or chronic pain. The official definition we use in medicine is pain that lasts for more than 3 months. It's no longer a helpful warning signal about tissue damage. Instead, the pain itself has become the problem. It's as if the nervous system's volume knob has been turned up to full blast and has become stuck there, broadcasting a pain signal long after the original reason for it has gone. This can be baffling and frightening for both you and your child. Understanding this shift from helpful acute pain to problematic chronic pain is the first, most crucial step. It's not all in their head, even though the brain is very much involved. The pain is real, physical, and can be utterly debilitating. Children with chronic pain might stop playing their favorite sport, miss school, or withdraw from their friends. Their world, once big and full of possibilities, can shrink dramatically. It's vital we recognize that this isn't a sign of weakness or exaggeration. It's a sign that their pain processing system has gone awry, and it requires a completely different approach to the simple paracetamol and rest we'd use for a straightforward injury. The journey for families dealing with persistent pain can be isolating. The child might feel that doctors are missing something, or worse, that you're not being believed. It's common to go from appointment to appointment, searching for a clear answer that never seems to come. But you are not alone. Chronic pain in children is more common than many people think, affecting as many as 1 in 4 young people at some point. The key is to unmask what's really going on, to look beyond the original injury and understand the complex mechanisms that can keep a child locked in a cycle of pain, and to know that there are effective ways to help them turn the volume down. To get to grips with why the child's pain won't go away, it helps to understand that pain isn't just one single thing. Think of it like ice cream. It comes in different flavors, and knowing which flavor you're dealing with helps you choose the best way to manage it. Broadly speaking, doctors think about 3 main types of pain. The first, and most familiar, is nociceptive pain. This is the pain I mentioned earlier, the direct result of actual or threatened tissue damage. It's the sharp pain of a cut, the throb of a broken bone, or the ache of a pulled muscle. It's caused by special nerve endings, called nociceptors, sending urgent messages to the brain about damage. The second flavor is neuropathic pain, and this is where things get more complicated. This type of pain doesn't come from an injury to the body's tissues, but from damage or disease affecting the nervous system itself, the nerves, the spinal cord, or the brain. It's like having faulty wiring in the body's electrical system. Instead of accurately reporting what's happening, the nerves send chaotic, incorrect, and often painful signals. Children might describe this pain in unusual ways, using words like burning, tingling, shooting, electric shocks, or pins and needles. It can be a very strange and frightening sensation, and it often doesn't respond well to standard painkillers. The third flavor is the newest one that scientists are getting to grips with, and it's called nociplastic pain. This is perhaps the trickiest of all. It describes pain that arises even when there is no clear evidence of tissue damage or a problem with the nervous system's wiring. Instead, the problem lies in how the central nervous system, the brain and spinal cord, processes information. It has become oversensitized and has learned to amplify pain signals. In nociplastic pain, even a non-painful stimulus, like the light touch of clothing or a gentle breeze, can be interpreted by the brain as excruciatingly painful. It's a key feature of conditions like fibromyalgia and amplified musculoskeletal pain syndrome, or AMPS. Crucially, in children, these types of pain are rarely neat and tidy. They often mix and overlap, creating a complex and confusing picture. A child might start with nociceptive pain from a fracture, but as it heals, they might develop neuropathic pain from a nerve that was bruised in the injury. Over time, if the pain continues, their central nervous system can become sensitized, adding a layer of nociplastic pain on top. This is why a simple approach often fails. We aren't just treating a sore leg anymore. We are treating a nervous system that has fundamentally changed how it experiences and interprets the world around it. Recognizing this complexity is the key to finding help that works. One of the most frustrating things for parents is when the usual remedies don't work. They give child paracetamol or ibuprofen, just as they would for any other ache or pain, but it barely touches the sides. This is a massive clue that you're not dealing with simple injury pain anymore. Standard painkillers like these are designed to work on nociceptive pain. They reduce inflammation and block the chemical signals produced at the site of an injury. However, they have little to no effect on neuropathic or nociplastic pain because these types of pain don't originate from inflammation or tissue damage. It's like trying to fix a software bug by hitting the computer case. You're targeting the wrong part of the system. The main reason pain can become persistent and unresponsive to simple analgesia is a process called central sensitization. Imagine a fire alarm in your house. Normally, it only goes off when it detects a significant amount of smoke. But with central sensitization, the alarm system itself becomes faulty and hyper-responsive. It starts to go off just from the steam from the kettle or a piece of burnt toast. In the body, the alarm system is the spinal cord and brain. After a period of intense or prolonged pain, the nerve cells in this system can become wound up and overly excitable. They start to amplify pain signals, making them feel much more intense than they should. This process explains many of the strange symptoms children with chronic pain experience. For example, they might develop allodynia, which is when a normally non-painful touch feels painful. The gentle weight of a duvet, a hug, or water from the shower can become unbearable. This is the burnt toast setting off the alarm. They might also experience hyperalgesia, where a mildly painful stimulus like a small bump feels intensely painful. This is because the sensitized nervous system is taking that small signal and turning the volume up to 11. It's not an exaggeration. Their brain is genuinely receiving a massive pain signal. This sensitized state can also cause pain to spread. A child might have initially injured their foot, but over time they start to feel pain in their entire leg or even in the opposite leg. This isn't because the injury is spreading, it's because the sensitized neurons in the spinal cord are becoming so excitable that they start misfiring and activating neighboring nerve pathways. This phenomenon can be deeply confusing and lead parents and doctors to suspect a new undiscovered injury, sending them on a wild goose chase of scans and tests that will almost always come back normal. Because the problem isn't in the tissues, but in the way the pain signals are being processed. While central sensitization is the underlying mechanism, it often manifests as specific clinical syndromes. One of the most dramatic is complex regional pain syndrome, or CRPS. This condition typically develops after a relatively minor injury, like a sprain or a fracture, most often affecting a hand or foot. The child experiences severe burning pain that is completely out of proportion to the original injury. The affected limb might change color, becoming blotchy, purple, or red. It can also swell up, feel intensely hot or cold to the touch, and the skin can become shiny and sensitive. CRPS is a powerful example of the nervous system going haywire, and it requires urgent, specialist management, usually involving intensive physiotherapy to get the limb moving again. Another major cause is, as we've discussed, neuropathic pain itself. This can arise when a nerve is directly bruised, stretched, or trapped during an injury. For instance, after a fracture of the upper arm, the radial nerve can be damaged, leading to weakness and a burning pain down the back of the hand. Sometimes a nerve can get caught up in scar tissue as an injury heals. leading to persistent irritation and pain signals every time the child moves. Treatment for neuropathic pain is very different from standard painkillers and often involves specific medications that work to calm down the overactive nerve cells, alongside physiotherapy, to gently mobilize the nerve. A rarer but very important cause of persistent pain after an injury is a missed compartment syndrome. This is a surgical emergency. The muscles in our limbs are enclosed in tight fibrous sheaths, like sausages in their skins. If an injury causes severe swelling or bleeding within one of these compartments, the pressure can build up dramatically, squashing the blood vessels and nerves inside. If it's not diagnosed and treated quickly by surgically cutting the sheath to release the pressure, it can lead to permanent muscle and nerve damage, resulting in chronic pain and disability. The key signs are the 5 Ps. Pain, which is severe and out of proportion. Pallor or paleness. Paresthesia, which is pins and needles. Pulselessness and paralysis or weakness. Finally, there is amplified musculoskeletal pain syndrome, or AMPS. This is a classic example of nociplastic pain. In AMPS, a child experiences very real, very intense body pain, but with no underlying injury or inflammation. The theory is that the body's normal pain reflexes get stuck in a loop. A blood vessel constricts, reducing blood flow and oxygen to the muscles, which causes pain. This pain then triggers more constriction, creating a vicious cycle. Children with AMPS are often incredibly high-functioning and push through their pain, but it takes a huge toll. The key to treatment is not rest, but an intensive exercise and psychology program designed to retrain the brain and break the pain cycle. As a parent, they are the expert on your child. They are the one who sees the day-to-day impact of their pain, and your observations are incredibly valuable. The first and most important step is to take a careful history. Keep a simple diary of the pain. When did it start? What was the original injury? What makes it better or worse? Does it change throughout the day? How does the child describe it? Using their words, like burning, tingling, sharp, or achy, can provide vital clues about the type of pain. Also, note down its impact. Are they missing school? Have they stopped seeing friends? Are they sleeping badly? This information helps a doctor understand the severity of the problem. When talking to the child about their pain, it can be helpful to use an age-appropriate pain scale. For younger children, a simple scale with smiley, neutral, and crying faces can work well. For older children and teenagers, asking them to rate their pain on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain imaginable, can be a useful way to track how it changes over time and in response to different activities or treatments. This isn't about getting a perfect scientific number, but about opening up a conversation and giving your child a language to express what they are feeling, helping them feel heard and validated. As a doctor, observe the painful area. Is there a change in color? Is it swollen? Does it feel hotter or colder than the other side? Gently test their sense of touch. Does a light brush with a cotton wool ball feel normal, or does it feel strange or painful? These are signs of conditions like CRPS. Watch how the child moves. Are they guarding the limb, holding it stiffly? Do they limp? Does their posture seem different? These subtle changes can reveal a lot about how their brain is trying to protect them from pain. Finally, it's crucial to gently screen for the emotional impact of the pain. Chronic pain and mental health are two sides of the same coin. Living with constant pain is stressful, and it can understandably lead to anxiety, low mood, or depression. Equally, pre-existing anxiety can make the nervous system more sensitive and predisposed to developing chronic pain. Ask the child how they are feeling in themselves. Are they feeling worried, sad, or hopeless? This isn't about blaming them or suggesting the pain isn't real. It's about recognizing that the brain and body are connected, and to treat the pain effectively, we have to support the whole person. No single person has all the answers when it comes to chronic pain in children. The idea that one doctor can find a magic pill or perform a single operation to fix the problem is almost always a fantasy. The most effective approach, and the one we advocate for in modern medicine, is a team approach. This is often called a multidisciplinary team, which is just a fancy way of saying a group of different experts all working together with you and your child. This team approach acknowledges that pain affects every aspect of a child's life: their body, their mind, their schoolwork, and their friendships. And so we need experts from all those areas to help. The cornerstone of the team is often a specialist physiotherapist. For a long time, the natural response to pain was rest. We now know that for chronic pain, this is often the worst thing you can do. It leads to deconditioning, weakness, and stiffness, which only makes the pain worse. A skilled physiotherapist won't just give your child a list of exercises. They will work with them to understand their fears about movement, set achievable goals, and slowly, gently reintroduce activity. They use techniques like graded exposure, pacing, and specific exercises to desensitize the nervous system and teach the brain that movement is safe again. Their role is to be a coach, building your child's confidence one small step at a time. An equally important team member is a clinical psychologist. This can sometimes worry parents, who think it means the doctor believes the pain is made up. This couldn't be further from the truth. A psychologist's role is to help the child develop coping strategies for living with a very real and difficult physical symptom. They can teach techniques like mindfulness, relaxation, and cognitive behavioral therapy, or CBT, to help manage the stress, anxiety, and low mood that so often accompany chronic pain. They help your child challenge the unhelpful thoughts that pain can create, such as "I'll never get better" or "I can't do anything," and replace them with more positive, realistic ones. The team extends beyond the clinic. It includes you, the parents, as well as teachers at school. It's vital that the child's school is on board. They may need support, such as being allowed to move around during class, having a modified PE schedule, or getting extra time for exams. A coordinated plan where the medical team communicates with the school ensures your child doesn't fall behind and remains socially connected. The role of parents is central. They are the coordinators, the advocates, and the emotional support. It truly takes a village to help a child navigate the complex world of chronic pain. But with the right team, the path becomes much clearer. Let's imagine a case, one I've seen variations of many times. Take 12-year-old Chloe, a keen netball player who fractured her ankle a few months ago. The fracture healed perfectly, the x-rays looked great, but 6 months later, she was still in agony. Her foot was swollen, purple, and so sensitive she couldn't bear the weight of a sock. She was missing school, had stopped seeing her friends, and was becoming withdrawn and anxious. Her parents were at their wits' end. This is a classic picture of CRPS. The key to Chloe's recovery wasn't another scan or a stronger painkiller. It was a referral to a specialist pediatric pain team. Her physiotherapist worked on desensitization, using different textures on her skin and getting her to put weight on the foot in a hydrotherapy pool. A psychologist helped her manage her fear of pain and taught her relaxation techniques. The most important message in all of this is simple, but it is the foundation of all healing. Believe your child. Their pain is real. The sensations they are describing are genuine. When a child feels disbelieved, it adds a layer of emotional distress that can make the physical pain significantly worse. Your validation and unwavering support are the most powerful medicines you can provide. Trust your instincts. If you feel that the pain the child is experiencing is out of proportion or has gone on for too long, it probably has. Don't be afraid to voice your concerns and ask for a second opinion or a referral to a specialist. Early intervention is key. The longer a nervous system stays in that sensitized, wound-up state, the harder it can be to reset it. Remember that the goal of treatment is not always to get pain down to zero. For some children, the aim is to turn the volume down from a deafening roar to a manageable background hum. The focus shifts from curing the pain to improving function. Success is measured by the child getting back to school, rejoining their sports team, laughing with their friends, and sleeping through the night, even if they still have some pain. It's about giving them the tools to be the boss of their pain, rather than letting the pain be the boss of them. This shift in perspective is liberating for the whole family. Finally, please hold on to hope. I have seen countless children, like our imaginary Chloe, who were trapped in a cycle of debilitating chronic pain, make remarkable recoveries. With the right support, a team that addresses the physical, psychological, and social aspects of pain, it is entirely possible for children to get their lives back. The journey can be long and challenging, with good days and bad days, but recovery is not just a possibility, it is the expectation. By understanding the nature of the child's pain, seeking out the right kind of help early, and providing a bedrock of belief and support, you can guide them out of the shadow of chronic pain and back into the light.